For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 2, Episode 31 of Surfing the NASH Tsunami, the second part of our preview of Digital ILC 2021, starts now.
This week on Surfing the NASH Tsunami.
But to Joern's point, his session is going to be this therapeutic discussion on what's new in non-cirrhotic NASH from a diabetologist point of view with Amalia, and then from a hepatologist view with Joern, and then, of course, what's new in cirrhotic NASH. And boy, is there a ton of things that are new. I'm surprised he's going to be able to cram all that into 10 minutes. To me, that's an hour-long discussion in and of itself. And then Jacob George coming onto the stage and talking about the challenges of real-life NASH management, and then this panel discussion at the end. To do all that in an hour, you want to just pull up a chair and hit rewind 100 times to get all the content.
I'm just struck by the amount of content this year on lifestyle and well-being. We're going back to the roots of healthcare, that it's not always in medicine. While we certainly don't have medicines available to treat NASH, there's a whole day of lifestyle and interventions, and more on the wellness side. So it's really impressive because it's the foundations of how we're going to be able to treat and manage a lot of people outside of medicine.
Next week, close to 10,000 stakeholders from across the global hepatology community will convene virtually for the Digital International Liver Congress 2021, a 4-day meeting with well over 100 sessions on a broad range of liver-related topics. Today, join hepatology researcher and key opinion leader Dr. Stephen Harrison, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, hepatology researcher and key opinion leader, Professor Joern Schattenberg, as they discuss the sessions and papers that interest them most today on the Surfing the NASH Tsunami podcast.
June, this year in particular, is a busy month for major events in the fatty liver community. Last week was International NASH Day with 8 top-notch panels, plus energized and energizing videos from advocacy groups and professional societies around the world. I, and most of the people I've heard from, believe the Global Liver Institute lifted all ships with tremendous energy, tremendous commitment, and a lot of really solid education. That was last week. Next week is Digital ILC 2021, where an estimated 10,000 liver stakeholders from across the globe will join virtually for 4 days of education and interaction. We at Surfing NASH, we're delighted to be part of the coverage of International NASH Day 2021, and we are both honored and delighted to be an official media partner for Digital ILC 2021. 2 weeks ago, Professor Luca Valenti of the EASL Scientific Organizing Committee joined us to discuss what he considered broadly to be the high points and innovative benefits of this year's conference. Today, Stephen has taken a break from an all-day taping session for his June 17th, 18th EASL AASLD conference to join us. Joern Schattenberg is with us despite the late hour in Europe, and Louise has stopped celebrating England's triumph in his opening Euro 2020 match to be with us. Hi, all of you. I will have more information on our EASL coverage during the business section, but for now, time is limited. So let's just jump into our usual icebreaker. One good thing has happened in the last week. Who wants to go first?
Well, I'll go first. This is Stephen. So actually 2 good things. Number one, we were talking about before the podcast, had a wonderful opportunity to take today and come up to North Carolina and visit with one of the icons, in my opinion, of American history, Billy Graham, and to visit the place he lived. I'm actually staying with one of his granddaughters and husband and their family, just a fantastic group of people. But interestingly, the individual I'm staying with is actually developing a compound for NASH that I think may be a game changer. And so we're going to talk about some of the principles of the compound. It's having to do with phospholipids and how we can defat the liver very quickly using mechanisms such as that. The other icebreaker that I think is great for me, my daughter, who has been accepted and will be matriculating at Southern Methodist University in the fall, also made a international co-ed competitive cheer team last week. And that's fantastic news, except I wasn't supposed to lose her until August the 19th when she would move out of the house and start college. Little did I know that practice for that competitive cheer team in Dallas, Texas started Saturday. So San Antonio is 5 hours away from Dallas. So essentially, I lost my daughter starting last weekend. So she'll come home for a couple days and then have to go back. But it's terrific for her, great opportunity. So 2 great things have happened, at least to me, in the past week.
Wow, that's difficult, Stephen. Congratulations to the fantastic achievements of your daughter. I can tell from a personal side, I took my daughter to track and field this afternoon. She's running around with a bunch of 6-year-olds, so there's some years in between that. But she did well, jumping, throwing, and running. But I guess there's good times coming.
Remember, Joern, the days drag by, but the years fly by.
Mm-hmm.
That's true. Well, let me just give you a quick professional highlight. Normally you get these calls. Hey, Dr. Schattenberg, you've done a liver biopsy on this patient. What's the result? How to interpret that result? Last week, I actually got a call by a physician who said, I got this FibroScan machine sitting in my office, and now I use this, and I got 2 numbers. So I got elastography, and I got CAP. Now, what should I do? I think it tells me I need more education of my peers there, but it shows me that the whole story moving beyond the biopsy is really catching up even in Germany in internal medicine practices.
Somewhere, Donna Cryer has his fist in the air and is pumping it.
That's an interesting concept. At least people have FibroScan machines. They might not know what they do, really, but I'm impressed he was able to get the results. I don't know what they were of, but entertainment there. Personal for me, well, youngest did mock A-levels this week, so for once in 18 months they've gone back to exams, and actually that whole tried and tested way of education and assessing it. So I think with some trepidation to start with, but learning to revise again was a skill in its own right. So it's nice to see the school education world getting back to normal for us.
And I guess mine is personal as well, which is as Pennsylvania certainly opens up again, you get events and rituals that you haven't had in 2 years. And we actually had one of the organizations that I'm on the board of had a cocktail party over the weekend, and I got to see people I hadn't seen for a year and a half, even though they're my neighbors. This is the kind of town where people just go out on the streets on Saturday night and run into each other. Obviously, that's not been happening. So as an easy social event and just great feeling at the end of the night, well, frankly, completely sober, that was about as good as it got. I was really happy about that. With that, why don't we dive into the episode? As I mentioned 2 weeks ago, all EASL abstracts and content are embargoed until next Wednesday's initial press conference. So what we've got to work with today as we talk about what interests us about this conference are titles and section talks, plus our own knowledge about the author's interests and backgrounds. Each of us has selected a few items we want to highlight that we think are of value. But first, I just want to ask a general question to the group. General reactions to this agenda. Are there things that you find particularly good or valuable about this agenda, or things that you wish might have been covered in a little more detail? Or are you perfectly happy with the way it is? Or you want to go first?
I'm going to go first on this one here. The challenge of having a virtual meeting is, of course, as we've highlighted the other discussions, is the lack of interaction. And when I look into the program, and I'm actually personally involved in one of those sessions, they created interactive sessions where you give pre-recorded talks, and then you have a fair chunk of the time, 45 minutes for discussion. I'm really looking forward to that. It'll help us to get back into exchanging views and actually being very close to the content that was presented, which is really at the heart of those meetings.
Just to build on Joern's comments, I think the way the program is laid out, it's good. It was very good last year, the virtual format. There have been some refinements to make it even a bit better. One thing we're limited a bit on is, again, understanding the content of what's being presented, as you noted already, Roger. But an easier way to maneuver through and in and out of the posters, I think, is headed our way, and something I'm looking forward to seeing this year with this virtual format. But to Joern's point, his session is going to be fantastic. Now, Joern is an all-star at this meeting, as with most meetings. He has multiple talents and is displaying all of those at this meeting. But this therapeutic discussion on what's new in non-cirrhotic NASH from a diabetologist point of view with Amalia, and then from a hepatologist view with Joern, I'm really looking forward to hearing what both of those academic experts have to say relative to where we're headed. And then, of course, not leaving out cirrhotic NASH. That's going to be a topic as well, what's new in cirrhotic NASH. And boy, is there a ton of things that are new. I'm surprised he's going to be able to cram all that into 10 minutes. To me, that's an hour-long discussion in and of itself about where we've come from this time last year, looking at cirrhosis, to where we're going. And I'll mention in a moment one of the presentations discussing therapeutic intervention for that stage of fibrosis that looks very encouraging. And then Jacob George coming onto the stage and talking about the challenges of real-life NASH management. And then this panel discussion at the end. Boy, that's going to be super rich, and I wish we had more than an hour to discuss this. I mean, to do all that in an hour, you want to just pull up a chair and hit rewind 100 times to get all the content that's probably going to be mentioned.
Louise, got anything in mind?
Yeah, I'm just struck by the amount of content this year on lifestyle and well-being. We're going back to the roots of healthcare, that it's not always in medicine. While we certainly don't have medicines available to treat NASH, there's a whole day of lifestyle and interventions and more on the wellness side. So it's really impressive that we're looking at the ways that the diets, the exercise, we're doing comorbidity management. It's good progress because it's the foundations of how we're going to be able to treat and manage a lot of people outside of medicine during the future years. So I'm excited by those parts that are increasing now, as well as the non-invasive technologies, obviously the discussions in and around how they're going to move forward and more evidence to hopefully move us beyond the biopsy in the near future.
I agree with you. And actually, that one session has me particularly excited because they're taking a look at non-invasive from a bunch of directions and in a bunch of different populations. I love the idea because it's always been one of my things that there's a talk about lean NASH and the differences in lean NASH in the midst of all that. And spoiler alert, one of the co-chairs of that panel is Michelle Long, who's going to be joining us that day, June 24th, for our same-day follow-up. So I expect that will get plenty of attention, given that the panel will have just happened and she'll be with us. I think that's a great thing. With that, why don't we dive in and start talking about specific titles of interest? And normally I do brave one go first, but if you've got one top of mind, why don't I let you start?
Yeah, I'm just going through the program. First day is going to be busy with the postgraduate course, which is really the flagship of ILC this year. And as Louise mentioned, there's going to be a lot of lifestyle, some very interesting topics of comorbidities and cofactors in NASH, alcohol, sleep, these type of things. And of course, the basic science course going in parallel. There's a lot of it talking on artificial intelligence. We've detailed that in the case of patient finding previously on this podcast, but it goes beyond this and tries to assess all these novel biomarker technologies, combining multi-omic data sets to better understand the pathophysiology. So I think those are the opening days and really great. But then if you look at the first session, which I believe is the NAFLD clinical aspects, except therapy, and Matthew Armstrong and Michelle Long are, as you said, chairing that. There's a number of abstracts that are very interesting. And Laurent Serfati is going to present on lean NAFLD from the general French population. It's called the NASH co-study. And we've discussed lean NASH a number of times in this podcast. And I hope it'll give us additional insights to better understand that subgroup that's so diverse in some aspects compared to our metabolically burdened and clinically obese phenotype patients.
Louise, you want to go ahead?
What I was looking at was some of the abstracts, and there are some interesting abstracts by a Dr. Roberta Folano, who I worked with at Imperial, and I'm excited about her diabetes abstracts because this was a project that just started not long before I left on a set of diabetic patients and a cohort. So it's real-world data on a large primary care practice, I believe, from diabetes, and she's got 3 abstracts in. One is abstract 950, a serum metabolic fingerprint may predict advanced fibrosis due to NAFLD in a cohort of diabetic patients. So I'm hoping some of this data is going to be as impressive as I started to see before I left Imperial, and really inform some of our practice on the diabetes comorbid cases with NASH. So that excites me. So I'm excited to see some of her work coming out.
Yeah, there's like a kid in the candy store. There's so many great presentations, at least those presentations that look very attractive from their title. And I guess I'll break mine down into sections. So the first section would be novel therapies. What's coming of age? What's cutting edge? What's new that we maybe have heard is coming, but we haven't had any real data yet? One of those is out of South Korea. This is abstract OS-768, a first-in-class small molecule targeting 17-beta-hydroxysteroid dehydrogenase 13 for the treatment of NASH. So really beginning to get after some of these genetic influences, whether it be PNPLA3, HSD 17-beta-13, or others. So I'm excited to see what that's going to look like. And then Mike Charlton is presenting abstract OS-2450, first-in-class orally active toll-like receptor signaling inhibitor, and I can't pronounce this, mosadimab. or PLAG, attenuates molecular, biochemical, and histologic features of NASH in vitro and in vivo. So I think that'll be an interesting one. There are many others that I could highlight even from this particular session, but they're not brand new, out of the box, tell me something novel like these two are. So I'm excited to see what up-and-comers there are.
Excellent. I'm going to take a slightly different spin on the same thing, which is that I've been looking at how some of these sessions are constructed and really been fascinated. And one that I really liked is the one that Vlad and Razio and Kathleen Corey are doing on Friday afternoon. The title is just NAFLD Therapy, but if you look at it, it starts with OS 427 from Ken Cusi, a human proof of concept in non-alcoholic NAFLD patients with PXL 770, novel first-in-class direct AMP kinase activator. It ends with Rohit Lumba talking about pemafibrate and S-PARM alpha improving liver stiffness by MRE and serum liver and lipid parameters in NAFLD. The bookends are both around lanifibranor. One coming out of the phase 2b native study and the other just saying the pan-PPAR agonist lanifibranor significantly improves cardiovascular risk biomarkers in patients with NASH. So we have two interesting different things as the bookends. If you go in one in either direction, you have lanifibranor, 2 papers. And then in the middle, we have treatment of NAFLD with intermittent calorie restriction, low-carb, high-fat diet versus standard dietary advice, randomized controlled trial, and interim analysis from a 72-week double-blind placebo-controlled multi-center paired liver biopsy of endoscopic sleeve gastroplasty in patients with NASH. So I think about all that together and I say there are going to be so many things. The talks are interesting, and the compare and contrast about what seems to provide how much benefit, how in what different ways, I think should be fascinating. I'm excited about several of the papers. I'm really excited about the whole session.
You know, Roger, now that you read this to us, this is really a session that all details metabolic mechanism of functions. I mean, there are 3 PPARs discussed, and there is weight change, weight loss, be it endoscopically or trying to improve insulin resistance with the intermittent calorie restriction. And this is a theme that's really been driven forward. You know, there's not a true antifibrotic in this session. That's something that strikes me here.
I agree with you. I mean, Stephen, Louise, thoughts, comments?
Well, I think that, as you guys have mentioned, that's another don't miss session on the 25th of June. I guess it's slated about an hour and a half runtime for those 6 presentations. The pan-PPAR lanifibranor, we've seen the top-line data. The manuscript hasn't come out yet, but this looks like 2 additional post-hoc looks at some of that data, which, you know, it's a gold mine. It's a treasure trove of data. There's a large number of patients treated over a decent period of time. So that's going to be very insightful and instructive. And again, you mentioned PXL 770. That's not their only molecule. Interestingly, Poxel has PXL 065, which is currently enrolling a very large phase 2b paired liver biopsy study. So this company, Poxel, based in France, actually has 2 assets that appear to potentially be therapeutic for NASH. So this one's not as far along, this direct AMP kinase activator, but it's very intriguing. And even as combination therapies begin to pick up steam, it'd be interesting to see how this direct AMP kinase activator might fit into that paradigm.
If I had to pick anything out of that session, it would be the treatment of NAFLD with the intermittent calorie restriction, low carb, high fat against standard dietary advice, because we've discussed numerous times, what is standard dietary advice? Is it as simple as a GP saying, eat less, move more? So I don't think we've ever seen a consensus for what standard dietary advice is. So it would be interesting to see what the comparator is for that. And we know that people, intermittent diets, it tends to be a lifestyle thing, that people can do it for a short period and then come off it. So I'm interested to see what the 2 definitions that are going to be discussed there. So that interests me.
You know, you just struck a nerve, Louise, and I'll just say the one thing that I am totally surprised that we don't hear more and more about is the role of omega-3s versus omega-6s. You know, omega-6s we get tons of in our diet. Corn oil, vegetable oil, it's in fried stuff, right? We can take really good foods and ruin it by frying it. What do omega-6s do? They activate arachidonic acid cascades, which directly have influences over all of the inflammatory milieu, to include NF-kappa beta and other mechanisms that lead to stellate cell activation. And whether it's reducing omega-6s or, quite frankly, maybe we just don't eat enough omega-3s, right? I mean, we don't see a lot of our NASH patients coming in saying, Doc, I'm sick of eating tons of deep water cold fish like salmon and other deep water fish. You know, can I occasionally have a hamburger? I mean, they don't say that, right? They come in the opposite. And such a simple thing to do would be to measure these ratios of omega-6s to omega-3s at baseline, institute some sort of therapeutic intervention. You change the ratio over time and see what happens to the liver in these patients. But I would love to see something like that happen, because to me, that's foundational in the management of this disease, in addition to all the other things of exercise and cutting the carbs, which I'm a huge proponent of. But I think we often overlook the simple part of the nutritional component, which is the omega-3s and omega-6s.
Well, I'm looking forward to covering your abstract in EASL 2023 on that exact topic.
We got to get to work, Louise.
You guys can do it together. Stephen, you may be left because you may know I eat a bunch of cold water fish and virtually never eat red meat. And the thing I did last weekend that I didn't mention on the personal best was, just for the heck of it, I went out and did a 10K, which I had never done in my life, just by myself, using my Garmin to monitor me. And when I got done, the thing I wanted was a hamburger. Go figure.
Roger, I know you can put back a really good beef tenderloin fillet. You have that capability. Throw in a little red wine with it. I'm not sure you could get any better than that.
No, I was going to say, yeah, I didn't even have to run for that. I just had to drive for 3 hours to get out of the car.
Me being vaccinated, I think I'll go on a trip and join you guys on that.
Yeah, great. You can hang out at the beach with me in Corpus or down on Padre Island, and then we can drive to San Antonio and eat steak and drink wine with Stephen.
And the worst case scenario, we should all get the podcast band together at NAFLD in Anaheim and do just that.
Oh, we're doing that. That's happening.
Does that mean I get to taste your deep fried turkey?
Oh, that's about the right time. Yeah, November. Yeah, it's the 13th, 14th, 15th or something like that.
It's a different meal, but it's a concept. Well, we're going to work on something. Why don't we go on to the second round? Stephen, you mentioned wanting to talk about cirrhosis and some of the cirrhosis papers, and I know that you're involved with one of them, and I know that you're embargoed. But to the degree that you want to talk about presentations or papers that cover that would be a great place to start this round.
Yeah, so just to give you a high-level overview without diving into the data, one of the late-breaker abstracts is one of the cohorts of the efruxifermin phase 2A trial was a cirrhotic cohort, and that data will be presented in its fullness at the late breaker session. But what's been pressed in the public domain is, it's not a huge study. We're talking about 17 patients, 12 on drug, 5 placebo, but a third of them having improvement in histopathology, taking them away from an F4 back to something less than F4, which you could say, okay, it's short duration of treatment, 16 weeks, but boy, did the non-invasive test move in a correlatory manner. And so it's proof of concept. I get it. But it's proof of concept that even a well-compensated cirrhotic patient potentially, and I'm very cautious with that word, potentially could improve. And so that should give us all hope that even these people aren't beyond our ability to make a big difference in their life with pharmacotherapy. So we'll hear more about it, but if anything, it becomes a platform to have a discussion, and hopefully more companies will jump on board in evaluating this huge unmet need. I mean, if you think about it, yes, Selonsertib studied it and it was unsuccessful. Others have studied it. If you look at Imrisecan looked at cirrhotics as well and didn't do much. We still have the reverse trial with Intercept that we're anxiously awaiting the results. That's a huge study. I think, if I'm not forgetting, Joern, isn't it like 900 people that are enrolled in reverse? This is the first time where we've actually seen movement in a positive direction. And we'll learn more about it and unpack that a little bit more at the liver meeting.
Just to jump in here and highlight something that Stephen says, the liver is really the big organ that produces a lot of those fibrogenic markers. So those don't come from the bone or other tissue. So if you're in a cirrhotic state and you reverse that immense fibrogenic response by a drug, this is something that's going to translate into benefit for the patient. I don't have any doubt on that.
Yeah, well, we're not saying 16 weeks of therapy is all you need. That was just the first shot across the bow, the first look to see if you're really defatting the liver to the degree that this particular FGF21 is, and you're moving some of these non-invasive tests significantly, we'll take a stab at seeing what's happening under the microscope. There's a lot more to do with it and a lot more to unpack, as I mentioned previously, but I think it's intriguing.
So, Stephen, I have a question. I'm trying to think of a drug that looked at cirrhosis and failed that did well against F3 patients. Certainly the two examples that you gave did not do very well anywhere. Have we seen that yet, even in trial? I mean, and efruxifermin obviously it seems to be has results suggesting they might do well against both.
In a cirrhotic trial, we haven't. So Madrigal has published their phase 2B results, and they're currently enrolling the registration trial called Maestro NASH. But there's also Maestro NAFLD 1, which will be showing 52-week data from the open label 100 milligram arm there. But in that study, there's also an open label cirrhotic arm. Now, those people aren't getting a liver biopsy. They're being treated for a year, and then we're looking at non-invasive tests like MR elastography, PDFF, FibroScan, ELF, ProC3, liver chemistry tests, but no biopsy. So that's resmetirom. Aldafermin, which just recently pressed their Alpine 2-3 results, and everybody was disappointed with the fibrosis response group. They are continuing to enroll what's called Alpine 4, which is their well-compensated F4 study. So the jury's still out on aldafermin. You can say what you want about the press release data. In my own opinion, and take that for what it's worth, I think it's clear that there is a problem with liver biopsy, not necessarily the pathologist, but the limitations that that pathologist is put behind when trying to look at paired liver biopsies from a relatively small sampling of the liver. You have sampling variability, observer variability, regression to the mean. There's a certain amount of disease that improves and worsens over a 1-year period of time. The Senna-Krivorok study showed us that. So unless you're bringing to bear, one of the things we've learned as we move this field forward is that maybe consensus reading is better. And if we have the opportunity to overlay that with some sort of artificial intelligence, digital pathology, there's enough data coming out now to say we could be more granular at showing the impact of pharmacotherapy on fibrosis and even the components of NAS and NASH. So the jury's still out, in my opinion. I don't think it's, that aldafermin doesn't work. I'm holding out hope for that F4 population. We have the BMS drug, pegbelfermin, and FGF21 functioning mainly through beta-klotho FGFR1C that has published their phase 2A data quite some time ago now. Many day study Valken 1 and Valken 2. I believe we should be hearing from Valken 2 was their cirrhotic population. But again, we don't have any biopsy data from pegbelfermin. In fact, just looking at every FGF21, that whole class of drug, the only biopsies we have are from the BALANCE trial, which is efruxifermin. And so we have a lot more data we need to collect relative to the FGF21 class. As far as other classes of drug, OCA's got their F4 trial, the reverse trial, but we don't have readouts from that as well. So Roger, at the end of the day, we don't have hardly anything in the cirrhotic field where the non-cirrhotic data showed a benefit, and now we have F4 data showing a benefit. That data set gets really small in a hurry.
Okay, I was kind of going in the opposite direction, and then I want to move on to something else, which is the places where F4 we clearly haven't seen a benefit don't tend to be places where we've seen a big promising benefit earlier in disease. Two you mentioned, right, were selonsertib and emriclocin, both of which just failed. It isn't they did really well against F3 and then they did terribly against cirrhosis. They just didn't do very well.
Well, that's true. But also remember, one thing that's been a little delayed when we begin to think about drug development in NASH is I think, have been a little bit more savvy at developing tools to tackle the metabolic side of the house, more so than we have to tackle stellate cells or extracellular matrix collagen deposition. If you think about the buckets of drugs that are targeting different pathways in NASH, we've got a lot of them that are targeting free fatty acid flux from adipocytes. We're trying to improve insulin sensitivity. We have drugs now that can get after de novo lipogenesis, whether it's an SCD1 inhibitor, an ACC inhibitor, a FASN inhibitor. We've got THR betas, we've got pan-PPARs, we've got PPARs, PPAR gammas. I'm sure I'm leaving out the FGF19s, the 21s. There's a lot of them out there. We have structurally engineered fatty acids as well. But when you look at antifibrotics, purely antifibrotics, we're a little bit limited. We got some early data coming with maybe pancyclophilin inhibition and others, but boy, we're just not as mature field yet in the purely antifibrotic play. Now, this is a plug for Scott Friedman. He's, in my opinion, the world's greatest liver fibrosis guy out there. He is working nonstop trying to help get some of these compounds into the clinic to study. But when we look at switching gears to pure anti-inflammatory plays, that's where we've seen the graveyard fill up in a hurry, whether it's CCR25 or it's selonsertib ASK1 inhibition or it's others. It's been a challenge. It doesn't mean you can't go after that market, but I think the issue there has been finding a clear market marker of target engagement. Are we hitting what we're trying to hit? And that was one of the issues with the ASK1 inhibitor, selonsertib. We couldn't really assess, were we getting drug on target and it doing what it was supposed to do. That's one of the keys in that space, is how do we know we're hitting what we're supposed to hit?
That's the mechanistical complaint. And I think they were just too soft in the metabolically burdened patient to go by themselves. So I think, as you said, they have to hit the target. But if they do, they might still need something add-on to get the job done.
Yeah, that's a great point.
So let's go back to the agenda of the conference for a minute and ask Joern, Louise, what else you've seen in the scientific program that we've not mentioned that you think has some particular value or interest?
That's not so much the scientific side. I'll leave that to Stephen and Joern. But what is encouraging is Friday, the 25th, there's a session on management in primary care and how we look at non-invasives in primary care, cardiovascular. What do primary care physicians think of liver disease? So I think it's really important to try and get to understand the issues with primary care. There's also a session on, with EASL and the World Health Organization. As you know, I advocate a lot for fatty liver disease and that being given an NCD status independently, which I don't think it has currently. But there's a lot of discussion going on about the NCDs. Where do they sit with liver disease? How prevalent is it in other areas? So I'll be interested to see those sessions, and that's between 2:00 and 3:30 on the 26th, and that's Karina Ferreira-Borges and Peter Jepson are heading that. So I think a lot of work that Donna's been involved in with GLI and the International Liver Foundation have done a lot of hard work with the World Health Organization on this. So we are progressing in all shapes and sizes throughout this program. It's very diverse, it's very inclusive, which is nice to see.
I'll give Louise some props here and just to talk a little bit about a session that is right up her alley and one that is going to be very helpful to the field. And that is this one on the 26th of June, shared by Laurent Castera and Michael Pavlidis, and looking at some of these non-invasive tests. Michael, it's great to see Michael get to be a chair of one of these sessions. I remember interrogating him at his EFIL, and he's come such a long way in a short period of time. But we're going to hear the development and validation of Agile 3, which is this novel FibroScan-based score, which it's a step forward. This Agile 3 is a non-invasive test that combines liver stiffness measurement, AST, ALT ratio, platelets, gender, age, and the presence of diabetes. And it's really targeting this more advanced population of patients, F3 or greater. But I think it takes us a step forward, if you will, one step further in our understanding of how to manage these people from a non-invasive perspective, how to diagnose them. And in that session, there's a whole lot of other key papers that are being presented. In fact, 2 from the Litmus Consortium that Joern and I both are a part of. So it'd be a very interesting session to check in.
Thank you, Stephen. Joern, anything else you want to comment on?
No, I agree. And the last day on ILC are normally all the highlights, and this is where it right falls in with the non-invasive tests, right together with the late breakers, I guess, which we haven't discussed yet. And Stephen is gonna believe, you mentioned that was the cirrhosis study, that fructofermin. But again, I think that's a great highlight and ending of that exceptional program we're going to see this year.
Joern, is there anything else on the late breakers you want to comment on? Because I have one comment I want to make on the first general session.
One I was going to direct your attention to, and I sent you that in an email, is a mechanistic study that was actually published in Nature by a German group, and Michael Dudek is the first author, and they took a mechanistic approach to explore the liver immunophenotype in NASH. And we've seen 1 or 2 great studies coming out here, one in the context of NASH HCC, and this one now here looking at CD8 cytotoxic T cells and looking what's going on in that inflamed liver. And it's a deep basic science approach to look at that. What it tells us as a clinician is that really we're getting to better understand the inflammatory phenotype that drives that disease and some autoaggression that's going on in the liver, and really looking forward to that talk to better understand the true pathophysiology of this.
Let me highlight one more and then closing questions. I thought the last 2 papers of the first general session, neither of which is particularly scientific, both I think are really important. First, a paper from the U.S., GS1072, on food insecurity is associated with all-cause mortality in U.S. adults with non-alcoholic fatty liver disease and advanced fibrosis. I don't think that's necessarily a surprising thing in some ways, but it's one of those things that to see proven and demonstrated in this context, I think will be helpful. Aligns, I think, neatly with a lot of the work that Donna does, and Louise, a lot of the work that you do, right? That people who are food insecure don't eat foods that help them. Stephen, you say you can ruin anything by frying it, and I totally agree with you, but you can also get more calories out of it that way. And people who are food insecure and don't have a lot of calories, I don't know that they worry so much about the long-term health quality of what they eat as long as the question is, does it make them hungry? So I'll be interested to see that one. And then the next one is about chronic liver disease and the risk of mortality after COVID-19, retrospective cohort study for 2020. Again, taking a look at the other side of that relationship, I believe, which is what does liver disease say about what happens when you experience COVID as compared to what does COVID do to the liver? Those are two other papers, not necessarily for pure science reasons, but I think for understanding where all this fits in the world at large and the other elements of policy and life that I'll be really intrigued to see.
I'm going to step out of my fatty liver lane and mention one abstract that intrigues me. And that is, and I don't have it off the top of my head, but if I remember right, it's amoxicillin and clavulanic acid, prednisone for the treatment of, was it alcoholic hepatitis?
Yeah, that's right. I don't remember who the author was, but that's right. That was the title.
Boy, that's an interesting combo because you take the number one drug for drug-induced liver injury in the U.S., Augmentin, and you combine it with prednisone. I'm intrigued by the mechanism behind which the thought was generated that might be a potential target. Joern, do you have you seen this abstract?
Yes, it's in your late breaker session on the 26th, and it's the first late breaking oral 2631 given by Alexandre Louise. From my perspective, they just use the high infectious risk these patients have and cope that with a broadband antibiotic and adding on prednisone to avoid the detrimental effects of immunosuppression in those alcoholic hepatitis patients. So I think, they want to get the good side of the antibiotic prophylactic exposure of those patients going on to an immunosuppression. And normally you use the Little score to determine the length of prednisone, but I'll be interested to see how they dealt with that. Maybe they're there to take prednisone longer out, and that's where the benefit kicks in. So, but I'm not sure. Looking forward. I agree. That's a great abstract.
Yeah, my only concern is if you take a sick liver and they're the one in whatever it is that has a DILI problem, well, that's going to be a bit challenging to bring that patient back. But it will be interesting to see for sure. And the good news is I get to listen to that because it's in my session where I have to wake up at, I think it's 3 in the morning, maybe 4 for that particular session. Since I'm going to be up anyway, I'll hear it.
Doesn't the late breaker start at 6? Well, 5. If you're going to be in Florida?
Yeah.
Yeah, 6. It starts at noon. 6? It starts at noon CET, so it'll be 6 in the morning. You're a lucky guy.
Well, the Panhandle, that's still 5 a.m.
Okay,
That's doable.
Watch the sunrise as you learn about Augmentin and prednisone. I like it.
And go for a run after that last presentation of yours.
That's right. I've got to, chase, I'll be eating fish down there. So, maybe I'll eat fish. We'll see.
Anybody have anything they want to add about the meeting before I go to closing question? About specific things about the meeting?
I guess I'm still wondering how they get the get together at the meeting and the interaction parts. We mentioned the interactive sessions, but I think there's going to be an element where you can actually reach out and discuss with peers, and I haven't really figured that out yet. So I'll be excited and looking forward to how that's solved.
Joern, I'm glad you mentioned that. Luca Valenti talked about that when he was on 2 weeks ago in terms of what they've done with the platform. That the platform is actually set up to foster group one-on-one conversations, groups coalescing around issues and just talking offline. So I don't know exactly what that's going to look like, but I know it's a source of real excitement for the EASL folks. And I agree with you. I think that the ability to generate those conversations will be a tremendous benefit.
I think the only thing I can say is this year, I think it is more inclusive of every speciality, every grade of healthcare professional, from nurses through to doctors. Obviously, there's a nurses and associate healthcare professional session on the 26th, I think it is, the Saturday. But there's lots of bits in between that really cover a lot, and plus patient interest. So I think this is the most diverse meeting that we've seen, and maybe that's because it's virtual, but it's exciting throughout.
So why don't we do this, knowing that we can't break an embargo, but I don't think anyone has to do that to answer this question. Grab your crystal ball, and based on what you know about this meeting, predict what you think will be one of the 2 or 3 big stories that will come out of it, ideally from a fatty liver perspective, but if the one you think matters most has nothing to do with fatty liver, this will be the moment to talk about it. Brave one, go first.
I'll be brave, and this is a big crystal ball that fatty liver disease will be given an independent, non-communicable disease status that lifts it higher in profile and places it with cardiovascular disease, diabetes, up at the top of the World Health Organization's agenda, because as we know, education and preventing liver disease can actually prevent some of those associated conditions. There's my crystal ball. We're going to break new territory with the WHO.
Just in the field of fatty liver, the consensus, the drumbeat is growing louder as there's a sense that we're getting closer toward an approved drug to treat the disease, that we're getting better at identifying at-risk NASH, that we're developing tools that are becoming more recognized as a predictor of therapeutic response, that we have tools that are now coming onto the scene that can predict outcomes. We had this International NASH Day. I think it was huge. It was a huge hit, in my opinion. And I think that groundswell of patient advocacy is going to be one of these tides that raises all boats. I think the general consensus coming out of this meeting is going to be one of, we're going to get where we want to be with fatty liver, but it's 2 steps forward and 1 step back. I mean, we've seen that with therapies reporting even this year. But I generally think that there's not going to be a new therapy that's FDA approved. We're not going to have some bombshell newscast on fatty liver that comes out of EASL. But I think the totality of the data will be one where people walk away feeling better about where we're headed.
Excellent. Joern?
And I agree with Stephen on this one. I think diagnostics is really the field where we've seen the most advancement. There's more granularity in the therapeutics field, but the diagnostics are really just skyrocketing. I mean, there are 2 big EU-funded projects. They're joining in a think tank on, I believe, Thursday morning. This is the Litmus Consortium that was mentioned before. And here, really great and groundbreaking work with regards to defining the non-invasive tools we want to use has been made. And then the other one is the Liver Screen project, which does case finding or even uses non-invasive tests to screen in not even high risk, but in the general population. And I think the amount of data that's generated across those large consortium is just gigantic. And that's why non-invasive tests are really stepping out of the meeting for me as being more broadly. We have a better database to understand them. And also the abstract that will be presented from the Litmus Consortium by Michael Pavlidis, as Stephen said, I think there's just so much going on in the diagnostic field.
So I had a coin toss, Joern, and since you hit heads, I'll hit tails. I think also there's more focus in this meeting than we've tended to see in the past on multidisciplinary issues, not just your session, but sessions that go into cardiology and other diseases. And I believe in the absence of having a lot of medications, which we'll get to but don't have yet, and in the presence of good diagnostics, the more specialties understand why this should matter to them, and the more patients understand about why this isn't simply about a fatty liver, I think the better we'll do at raising the salience of the disease in the eyes of the world, and that gets to more focus on diagnostics. It gets to Stephen's point about just a rising tide lifting all ships, and ultimately in the direction Louise wants to go. So I think the multidisciplinary piece is also important here. With that, Stephen, you committed 45 minutes. You gave us 52. Thank you so much for that. And go back to recording, and we will see you back here on the 28th for the wrap-up session at the end of this event. Joern, Louise, thanks everybody. And I'm going to hang this up so that everyone can get off, and I'll come back and do the opening of the business session and all that. Thank you, everybody. And with that, I want to thank our panelists, all of whom were superb as always, and move on to the business portion of our meeting.
Here are dates and times for our Digital ILC podcasts.
Next week, we will have a very different schedule because of EASL, Digital ILC Conference. We anticipate sharing one-on-one interviews Wednesday night and perhaps throughout the week, and then we will have daily sessions Thursday, Friday, and Saturday, dropping late those evenings in the U.S., early the following morning in the EU. Stephen will be on vacation, but Louise and Joern will each be here once, along with other folks you know, like Manal Abdelmalik, Naeem Al-Khouri, Mazen Noureddin, Donna Cryer, and then some folks you don't. We'll be posting names on LinkedIn, Facebook, and Twitter, and sending emails to our mailing list during the week. We will also be posting the titles that folks plan to discuss on the podcast.
Do you want to be part of a live audience?
Speaking of what we can do with an email address, we will be inviting listeners who give us email addresses to join our live recording sessions next week during EASL. The live sessions come with 2 major benefits. First, you get to hear the entire recording session in real time, including comments that we might cut to shorten the sessions, personal byplay between the panelists, and the ever-popular bloopers. Second is the more important benefit.
Want to be a star? This might be your shot.
Members of the live audience can submit questions to us while we are recording, and if we choose to use your question, we will invite you on the podcast to ask it and follow it up with us in real time. You can tell your families and coworkers to download the podcast and hear you be a star.
Here's a sneak peek at July events.
A couple of things to keep in mind for July. I will be taking a 7-day electronics-free break in the middle of the month. Donna Cryer will be substitute hosting with a fascinating topic. That episode will drop on July 14th, and I'll get you more information on it after EASL. July 23rd marks the 1-year anniversary of our move to Buzzsprout, and we are planning some special anniversary events for the podcast that airs on July 28th. If you have favorite moments from the past year that you'd like us to bring back or talk about, send an email, message me on LinkedIn, or post to the discussion groups, and we will get it on that episode. That's July. So finally, and as always, I want to thank our exceptional team. Mike Wilson, Wilson, who is cobbling together even more stuff today than usual, although I think I've said that every week for the last month, and it's always been true. Eric Rounds and Paulette Lee, who get things to go behind the scenes and make the social media and technical support work. And you, our listeners, who make this all worth doing because of your comments and your feedback and just the general good karma you send us. So with that, I wish everyone in the Northern Hemisphere a wonderful early summer weekend, everyone in the Southern Hemisphere temperate weather, and everyone with a team in Europa 2020 or the Copa America success for your team. Beyond that, stay safe. We'll see you next week for Digital ILC. Bye-bye now.
You've been listening to the Surfing the NASH Tsunami podcast. Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website. Thanks for listening. See you next week on the podcast.